Hi again everyone, welcome to the third of my series of videos about labour and delivery. These will make more sense if you watch them in order, so if you haven't watched the other two already, I'd suggest that you do that first. What I wanted to talk about in this video is trauma to the perineum, so tearing in labour, which is understandably something that's often on the mind of women as they're preparing for labour or sort of getting closer to labour. Unfortunately, it is pretty unusual to have your first baby with no tearing at all. It does happen, but it's kind of the exception rather than the rule. And most women having their first baby will have a minor degree of trauma to the vagina and the perineum, what we call a first or a second degree tear. The good news is that although it might need some stitches, it usually recovers really well. Women often ask me about episiotomy, so that's a procedure where a doctor or a midwife will make a cut in the vagina and the perineum with a pair of scissors. I know that sounds barbaric. It's nowhere near as terrible as that description makes it sound, although no one ever believes me when I say that. An episiotomy, from an anatomical point of view, is similar to a second degree tear. So if it looks like you're going to have the kind of average first labour tear or less than average first labour tear, there's really no advantage to an episiotomy. So we don't generally do them routinely. Where we do an episiotomy is if we think that you're likely to have more damage than that, sustain a bigger tear, which can create other problems, and we perform an episiotomy in the hope that we can avoid a bigger tear. I'll always try, in cooperation with you, to deliver the head as slowly and as carefully as possible so that we can minimise damage to you and reduce tearing or a need for an episiotomy. Assessing whether or not you need an episiotomy is really something that I can only do as you're delivering, as the head's coming out. So I would suggest that you leave it to me to make that assessment, knowing that I've done it lots of times before and I'm not going to make a cut unless I think that you need one. But if you're not happy with that approach, then please talk to me when I next see you in the rooms. When we use the instrumental deliveries, so a vacuum delivery doesn't change the rules. It's still an assessment we make at the time. With a forceps delivery, it's almost never a good idea to do a forceps delivery without also cutting an episiotomy. Another thing I like to run through with people is when to come into hospital once things start. And if you think that you're going into labour, the best thing to do is call the labour ward and speak to the midwives about what's happening, and they'll work out with you whether it's time to come in. The numbers for the labour wards are on the fridge magnet that I would have given you early in the pregnancy. If you don't have one of those, remember to ask me for one next time I see you in the rooms. Put it on the fridge or the washing machine or somewhere where it's easy to find once things start getting exciting. There are essentially 4 reasons that we get you to come into hospital. If you're contracting, if your waters break, if you have any bleeding, or if your baby's not moving. And I know that you're all sensible enough to call me if your baby's not moving or if you have any bleeding. With contractions and labour in general, contractions usually start irregularly and get progressively more regular, with the contractions lasting longer and getting stronger. That usually happens over a few hours, although no 2 labours are the same, so there's no exact recipe here. Often you'll have some mild irregular contractions that will then settle down and go away, only to start up the next day or the next week as your body's getting ready and preparing itself for labour. The difference between that warm-up phase and real labour is that labour progresses, so things get more regular and they get more intense. We usually get you to come into hospital when you get to the stage that contractions are 5 minutes apart, are lasting a good minute or so, and have a fair bit of bite to them. And usually at that stage in a first baby, there's still plenty of time to get into hospital and access whatever pain relief you need, check that the baby's okay. There's usually still quite a lot more of the labour to go. If you do start having some mild irregular contractions, I'd suggest that you have a rest, have a lie down, maybe take some Panadol. If it turns out that it was a practice run, then at least you've had some rest. If it turns out that it was the start of labour, getting a little bit of rest early on is going to help you as things progress. You want to save your strength for when things start getting more intense. It doesn't always unfold like this. Some people never really settle into that regular pattern, but their contractions get more intense and they need to come in. Some people, things don't change, but the contractions just keep going and going and going for hours, and we usually then will get them in to check that everything's okay. And some people will just start contracting every 2 minutes right from the outset, and those people just need to come into hospital. In terms of the waters breaking, for most people, the vast majority of people, the contractions start first and your waters break along the way. But for a small number of women, the waters break. Most of them will then go into labour, but some don't labour straight away. And the waters breaking is sometimes not as obvious and certainly not as dramatic as the movies make it look. Sometimes it can be a bit unclear as to whether the waters are broken or not, and if you're unsure, then you need to call me or call the labour ward. Sometimes the only way we can tell is to get you in and examine you. If the waters are broken and you haven't gone into labour, then we would at some stage consider an induction of labour, but depending on what's been going on in the labour and the results of various investigations along the way, often we don't need to do that straight away, so we'll wait a few hours or sometimes even a day to give your body a bit of a chance to start things off on its own, providing you're okay and the baby's okay. Usually I find that the midwives are fantastic at talking through that process with you and deciding when it's time to come into hospital. And calling the delivery suite if you think you're going into labour is always the best first step. The midwives will take into account how far away you are, what time of the day or night it is, whether you've got other things you need to organise, like another child you need to arrange care for. And usually I find that they nail it. But if they give you advice at any stage that you're not happy with, then please give me a call. We'll talk through, so during the day, give the rooms a call, after hours, call the paging service, and we'll talk through what's happening and come up with a plan that we're both happy with. Once you arrive on the delivery suite, the midwives will spend some time with you assessing you. They check that you're okay, assess the baby, make sure the baby's okay, and sit with you for a while to get a feel for the pattern of your contractions. They then give me a call and I'll generally then come in and examine you, find out where we're starting in terms of how dilated your cervix is, and then we make a plan from there. Since every labour unfolds differently, it's hard to give you a clear guide as to what happens from there. But broadly speaking, once you're in established labour, most people progress along at about 1 centimetre an hour. That is just an average, so it's totally normal and completely okay to be faster than that or slower than that. But when we're examining women to see how they're progressing, we try not to do it closer than about every 3 or 4 hours to give your body time to actually make some progress so that we can see what's happening. Of course, there are definitely reasons to examine you sooner than that. If we're worried about anything, then we tend to examine you and find out what's happening. If you're showing some signs that you might be fully dilated quicker than anybody is expecting, then of course we'll examine you. And if you think it will help you make a decision about pain relief, to know how far along you are, then I will examine you. The midwives will be with you most of the time during the labour. I'll be in and out throughout the labour. During the day when I'm in the rooms, I'll pop up and back between the rooms and the delivery suite in between patients. After hours and on the weekends, I live very close to the hospital, so I'll just pop in and out. And usually once you get to the second stage, the pushing stage, I'll be with you in the room the whole time. That's all for now, but check back in from time to time. As I think of more topics, I'll post some more videos, and I'll see you in the rooms or on the labour ward soon.